Welcome to this video on the cardiomyopathies. These are diseases of the heart muscle, distinct from issues with valves, coronary arteries, or the pericardium. Today, we will explore these conditions using a case-based approach, following one patient's journey to diagnosis and management, while building a simple framework to organize every type you will encounter. We begin with our patient, a 54-year-old man we will call Mr. Daniel Okafor. He presents with 3 months of progressive breathlessness, ankle swelling, and orthopnea. His symptoms suggest classic heart failure, and our goal is to determine the underlying cause of his cardiac dysfunction. In this video, we will define cardiomyopathy, classify the major patterns, dilated, hypertrophic, and restrictive, and connect these shapes to their functional problems. We will also review the primary causes, key diagnostic tests, and management strategies, including how to identify patients at risk for sudden cardiac death. Mr. Okafor's history reveals his breathing worsens when lying flat, and he experiences paroxysmal nocturnal dyspnea. He reports profound fatigue, yet denies chest pain, fever, or recent viral illness. These symptoms highlight the heart's inability to move blood forward effectively, causing congestion in the lungs and legs. His background provides critical clues. He has no history of coronary artery disease, but does report chronic heavy alcohol use, a known toxic cause, and a family history of an enlarged heart, which points toward a possible genetic origin. Both are strong leads in our diagnostic investigation. Physical examination confirms congestive heart failure. We observe elevated jugular venous pressure, a displaced PMI indicating an enlarged left ventricle, an S3 gallop, and a murmur of mitral regurgitation. The displaced apex strongly suggests the heart chamber is dilated. A cardiomyopathy is defined as a disease of the heart muscle itself. It leads to systolic dysfunction, where the muscle cannot squeeze effectively, or diastolic dysfunction, where the muscle is too stiff to relax and fill properly. Importantly, this is distinct from primary valvular, coronary, or pericardial disease. To organize these diseases, we use a 4-shape framework. There is the normal heart, the hypertrophic heart with thick walls and a tiny cavity, the dilated heart with thin walls and a huge cavity, and the restrictive heart with stiff walls. Recognizing these shapes is key to understanding the underlying mechanical problem. The shape of the heart is often a response to stress. Pressure overload, such as hypertension, causes the muscle to thicken, leading to hypertrophy. Volume overload, however, tends to stretch the chamber, leading to dilation. Mr. Okafor's clinical presentation places him squarely on the side of a dilated cardiomyopathy. Dilated cardiomyopathy is the most common form you will see. It involves global reduction in contractility without external causes like coronary disease. The hallmark is a low ejection fraction, often below 40%. Genetic factors are identified in over 35% of these cases. The causes of dilated cardiomyopathy are diverse. They include genetic mutations, toxic exposures like alcohol or chemotherapy, infectious myocarditis, peripartum complications, stress-induced Takotsubo, and chronic tachycardia. For our patient, chronic alcohol use remains our leading suspect. Mr. Okafor's workup includes an ECG, which shows a left bundle branch block, and blood tests to screen for reversible metabolic or infectious causes. However, the echocardiogram is the essential test. It confirms his diagnosis of dilated cardiomyopathy, showing an enlarged left ventricle with an ejection fraction of 25%. Hypertrophic cardiomyopathy presents a very different picture. Here, the left ventricle wall is 15 millimeters or thicker, caused by mutations in sarcomere proteins. This leads to fiber disarray, which creates a substrate for arrhythmias. It is notably a leading cause of sudden death in young athletes. In hypertrophic cardiomyopathy, the thickened septum can obstruct the outflow tract. During contraction, the mitral valve can be pulled into the path of blood flow, worsening the obstruction and causing mitral regurgitation. This process is dynamic and worsens when the ventricle empties, such as during increased contractility or decreased filling. Recognizing hypertrophic cardiomyopathy is crucial. While many patients are asymptomatic, others experience dyspnea or angina. A vital high-yield finding is the murmur, which paradoxically grows louder when the ventricle is emptied, such as during a Valsalva maneuver, unlike the behavior of aortic stenosis. Treatment of hypertrophic cardiomyopathy aims to relax the heart and relieve obstruction. We use negative inotropes like beta blockers or verapamil to soften the squeeze. We avoid vasodilators and dehydration, which worsen obstruction. For refractory cases, surgical myectomy or alcohol septal ablation can thin the septum. Finally, we implant defibrillators for high-risk patients to prevent sudden death. The third pattern is restrictive cardiomyopathy. Here, the ventricle is not dilated or necessarily thick, but the muscle itself is stiff. This restricts filling, causing high pressures behind the heart. It is critical to differentiate this from constrictive pericarditis, where a rigid sac rather than the muscle causes the problem. The key question here is what is making the muscle stiff? Restrictive disease often results from infiltration. Amyloidosis is the primary concern, creating a paradox where walls look thick on echo but show low voltage on ECG. Sarcoidosis causes inflammation through granulomas and often leads to heart block. Other causes include hemochromatosis and rare storage diseases. Identifying the cause is essential, as some, like amyloid, now have specific, targeted therapies. Myocarditis is another critical consideration, often presenting as a mimic of other conditions. It involves inflammation of the muscle, typically viral in origin. It can be silent, simulate a heart attack, or lead to cardiogenic shock. Certain types, like giant cell myocarditis, are aggressive and require immunosuppression. Prompt recognition is essential for patient survival. To summarize our diagnostic approach, we start with a patient in heart failure and use the echocardiogram to define the heart's shape. Dilated hearts require a search for toxins and genes. Thick walls suggest hypertrophy or amyloid, while stiff, normal-sized hearts require an investigation for infiltrative processes. MRI, labs, and sometimes biopsy confirm the diagnosis. Risk stratification focuses on identifying who is at risk of sudden death and who will progress. In hypertrophic disease, specific risk scores guide defibrillator use. In dilated cardiomyopathy, a persistently low ejection fraction is the primary driver. Regardless of the type, treatment targets the heart failure, the underlying cause, and management of rhythm issues and blood clotting. There are several pitfalls to avoid. Do not dismiss thick walls as simple hypertension. Look for the low-voltage ECG paradox. Remember the unique hypertrophic murmur that worsens with standing. Never miss giant cell myocarditis in a failing young heart, and always screen for reversible causes before considering an implantable device to address chronic heart failure. Returning to Mr. Okafor, we have assessed him with dilated cardiomyopathy, likely alcohol-related with a potential genetic factor. Our plan is to initiate guideline-directed medical therapy and ensure strict alcohol abstinence, which may help reverse his heart function. We will screen his family and reassess his ejection fraction in a few months to determine if an implantable defibrillator is necessary. To wrap up, cardiomyopathies are diseases of the muscle, categorized by three primary shapes. Dilated is weak, hypertrophic is thick, and restrictive is stiff. The echo identifies the shape, and further testing reveals the specific cause. By combining heart failure therapy with targeted management of the cause and rhythm, we can significantly improve patient outcomes. This video was developed using established pathophysiology and clinical guidelines from organizations like the ACC and AHA. While these sources provide a comprehensive overview, please remember that clinical practice requires verifying specific drug thresholds and risk assessments against the most current local guidelines. Thank you for watching.